Hello, I am Jennifer Lardy, and joining me today is Mrs. Marcie Williams, the Vice President of Safety and Risk Management for Texas Health Resources. Mrs. Williams is responsible for patient safety, risk management, environment of care, and emergency management. Mrs. Williams holds a bachelor's degree in healthcare administration and a master's degree in business and management. She is also nationally certified in patient safety, risk management, safety, and legal nursing. Mrs. Williams, thank you so much for taking time to meet with us today. As you know, patient safety is paramount in every aspect of healthcare and is an inherent part of nursing. As future nurse leaders, it is important for us to understand the importance of patient safety culture. How would you define patient safety culture, and why is it important in healthcare?
You know, I get that question quite frequently because we know culture is what drives the organization. It's what drives departments. It's what drives individuals. And so I think the best definition that I have found is culture is how we do things when no one's looking. It's because it's our core. It's our value. And so, you know, I don't need you as my supervisor watching me with hand hygiene because I know that it's important to patient care, so therefore I'm the one that owns it. So it's our ownership of patient safety. That's culture. Culture is the driving determinant of how we achieve our outcomes that we expect, how we improve our patient safety initiatives, how we take care of our patients, how we engage them. It is our driving force. So therefore, we put a lot of focus on driving culture, changing culture, and then monitoring culture to make sure that we sustain those improvements.
What are the national trends related to the current... What are the current national trends related to the culture of patient safety?
Well, I think a basis for culture is that we have to drive a just culture. Healthcare is really known to be in a punitive environment, and so we have tried changing that into what we call a just culture. That's a nationally recognized program where we no longer look at the outcome of the patient when we have an event. That's been a driving force throughout my risk management career. People would want to know who did what, and that was kind of the first question they asked, not what process was involved, you know, what were the outstanding circumstances around the particular bad event that occurred. And so as we drive just culture and people want to go to, now, who was responsible for it? Well, I don't know who was responsible for it because I haven't completed the investigation. And so we've been teaching our leadership as well as our physicians are ones that are sometimes key drivers in wanting to know who the individual was. And so in a just culture, you really focus on, you know, what was going on and that you do accept that human error does occur. And that if a death is caused by an event because of something that some individual may have caused, human error is inevitable in all of us. And so that's why we spend so much time hardwiring as much as we can, because we truly accept human factors engineering. And if I was getting into patient safety and wanted to know more about culture, I would be really focused on understanding human factors, because as humans, there's only so much we can do. There is only so much we can remember. And distractions are a leading cause of error because of being a human. So just culture is a real driver. We've been in just culture about 7 years now, and we have it built into our event reporting system so that people have to think about, was it the process that drove the error, or was an individual that made that selection and that was my behavioral choice? And that's when we determine then if it needs to go to peer review or what other actions by human resources we might want to take. But it really is divided into human error, at-risk behavior. I knew what the policy was, but in my estimation, I could do that workaround safely. And then, of course, we always have knowingly unsafe behavior. And that's when I know what the policy is. I've been visited with my manager or leadership by it, and I know what the expectations are of the organization. And I've elected in my behavior, in my practice, not to accommodate what I knew the expectation was. So just culture is a real driver of changing your patient safety culture. And another thing that's really out there in the research that's been more recent is medical team training. And I've learned so much about it because we have implemented Team Steps, which is the largest medical team training program in the United States. And the driver of it is that people think they work as a team member because, you know, we want to get along, we want to work and support each other. And in healthcare, people really do care about each other, not just patients. We want to work well together. But it's been proven in the research that you have to teach team training. And as you get into it, you'll learn what the communication techniques are. So Team Steps is the largest one, and that's the one that we've adopted throughout our system. So I think those are two key drivers as we look into what's going on nationally around culture itself.
Great. So I guess that kind of feeds into the initiatives that contribute to building a patient safety culture. How would you measure those?
Patient safety, it's very interesting. People do want measurements, and rightfully so, because we want to make sure that we're spending our resources wisely. But I drive that patient safety is a culture. It is a core value. In the beginning of patient safety, I think people looked at it when the programs you implemented were just that. They were the programs. But as we've learned more about patient safety and the programs that will drive change, it is a core value. It's like saying, how do you quantify your mission statement? Very difficult to do. So how do you quantify patient safety? Now, we go a lot with if we have a reduction in falls or medication errors. The national numbers are out there. What does an average fall cost? And then you can take that, and as we reduce those falls, we can say that we're doing cost avoidance. And that's probably the best you can do with finance. As we implemented barcode medication verification, I had to do some big presentations to finance for them to understand why I wanted to spend $1 million+ on reducing medication errors. And that was built around, number one, that this organization, which I am thankfully a part of, and many of our organizations in our local communities really do support patient safety being a core value. So it's not a hard sell when you can really demonstrate that the evidence demonstrates that if you implement barcode medication verification, you will have a reduction in your medication errors, and a significant one, and especially in your major, moderate, and catastrophic events. And so you drive it from the cost avoidance factor. And that's really how you quantify a lot of patient safety initiatives, because many times I don't know how many patients I'm going to keep from falling, but I do know what the research and evidence-based practices have demonstrated as the research has been done. And that's what you drive your initiatives on that you want to implement system-wide or in your own hospital.
Okay. So what communication techniques would you say are essential to establishing a safe patient culture?
I would say, and patient safety always begins with leadership. And a lot of things are drivers from leadership, but the research does demonstrate that if I don't have strong leadership that's out there supporting when the patient safety officer's not around or the risk manager's not around, that you will fail in a lot of your patient safety initiatives. So the communication from leadership is very important. That patient safety is number one on the agendas. We really strive for that to be in our leadership meetings, and that it's always addressed. And then because that kind of lets the staff know this is a key performance indicator for us. And then also the just culture mentality has to be there. And people really do watch on that. And we've recently had an event where emails were inadvertently deleted, and you know how stressful that can certainly be. And I know as they got around the table to have the discussion, what we call a debriefing of how this event occurred, someone in the audience, one of the managers said, we have to follow the just culture algorithm on this. We know that some want to ask, who was responsible for this, who made the error in judgment or in the process to delete all these emails. But really, the manager spoke up and said, we have to follow the just culture algorithm. What we found with that was it was a process deficit that led to that human making that error. And so therefore, again, it was just strictly human error. The human did not want to cause that and did not do any at-risk behavior, but the processes aligned so that staff person was driven to make that error. And so that's interesting to watch, and that's very important. That didn't come from the leaders in the meeting. That came from managers saying, now just a minute, we're not going to hang anybody on this because we believe in just culture here. So having that just culture, that non-judgmental attitude, which we as humans, we all know we go to judgments very, very quickly. Yes. And so when you're in risk management or patient safety, you really do have to fight that human, event that you want to do, because as humans, we automatically go to judgmental characteristics many times, and it's very important to make sure that our body language doesn't reflect our judgmental attitude. So those are some key things that I would say in communication you want to make sure that you have in place to drive a strong patient safety culture.
Okay. So how do you feel about evidence-based practice and how it impacts patient safety culture?
I think it's very important. In the early days, 1999 is when really patient safety with the IOM report became an official term in a career path. Before that, when a lot of us were involved in risk management, we called it proactive risk management. But when the IOM report came out with all these patient safety drivers, it really took on its own career path and its own terminology, if you will. And so some of the main things that we think that we have to look at in supporting evidence-based, early on we didn't have the evidence there, but the Agency for Healthcare Research and Quality, AHRQ, is the research arm of CMS, and so CMS pays a lot of attention to what AHRQ has to say, as well as the National Patient Safety Foundation also does a lot of research. So we watch those people a lot, very closely, to see the research that they're doing in patient safety. And then as they do demonstrate the benefit of certain patient safety practices, then we try to adopt those. Many times, again, it's the physician culture, because many things that come out of research are driven by physician practice. And I'll go to the 39-week elective deliveries. It used to be that if mom or the physician's going on vacation, or the mom is one of those career-minded mothers that say, I want to deliver before budget starts, then they would deliver those early babies, 36, 37 weeks. But what the March of Dimes and other agencies have demonstrated, that if you have an elective delivery before 39 weeks, your NICU admissions go up, length of stay for those babies goes up, and then of course harm for those babies that happens. And that all came through evidence research. But now we have to convince our physicians, who have not had, the ones that have not had any problems, they were taught that they could deliver early, and to convince them of the evidence. Because many times that does involve them economically. It does involve patient satisfaction, because if I don't want to deliver during my budget process, because that's a very stressful time and you need to be at work, and it's really educating the public as well as the physicians that this practice has to change. So as you get evidence-based research, you may want to adopt it early on, but you have a lot of stakeholders that have to be convinced in the evidence itself. And sometimes that can be very difficult to do.
Yes, I agree. What role do you feel that nursing leadership has in developing and nurturing the culture of safety?
If you're talking about hospitals, because right now we're looking through the continuum of care. We look at physician office practice, we look at hospitals, and then we're looking at the nursing home, skilled nursing units. But if we're focused on hospitals right now, nursing drives 80% of the population, 80% of the work. And that certainly does not mean that a lot of other disciplines don't support patient safety. And I really, that has to be a strong message, because sometimes other ancillary services feel like they're being taken over by nursing. And we don't want that, because it is a team effort. But nursing leaders are the drivers. They are the one that sets the expectations. And more importantly, they are the ones that hold people accountable. And for our system alone, I will tell you that as we look at our patient safety culture survey results, and we see who's stronger in patient safety culture than others are, many times we can look at it and we look at nursing leadership. Is nursing leadership not only strong there, but are they strong at holding people accountable? Accountable in a just culture. That, just culture doesn't mean that we don't ever do corrective actions. It means that we're accountable for our actions. And it means that we don't have that punitive automatic, you made a mistake and therefore you'll be written up. But that we do have an accountable organization. And nursing leadership does drive that accountability. So you set the expectations and then hold people accountable for those results. That's what nursing leadership drives for patient safety.
Okay. So as a concern for all healthcare leaders, there's a cost of creating a patient safety culture. Do you feel like this cost can be recouped?
I do, and it depends totally on the initiative itself. But again, I reflect that patient safety has to be a core value. And so when many times you do, if I know that's going to take additional resources, if it's going to take an additional work group, if it is going to take us bringing in a contractor to help us get started, because we're a very large organization and sometimes we have to look at that. Then yes, they want to know what's your return on investment. And we do a fairly good job of really trying to strive to achieve that, because I typically know what the questions are going to be. But there are some things that are just out there that it's the right thing to do. And that's when core values set in. And so, and I will tell you, stories do sell. And so if I was trying to sell a patient safety initiative that there's not a lot of evidence out there about it, but it's the right thing to do for your organization, then you tell those stories. And stories do sell. Data tells, stories sell. And many times you can reflect on a bad event with a bad outcome, and we all have them, no matter where you work. And so you reflect on those stories, and that really does drive that this is part of our core value, and we do not want this to happen again. And this is what's going to take for us not to happen again. Because anybody, you hear about bad events and you go, oh my goodness, how could that happen? And that's truly people that don't know operations, because any bad event can happen anywhere to anyone. I've seen the best of providers, physicians and nurses, make egregious errors with terrible outcomes, and that really does drive home the fact that anybody can make errors. We are all human.
I agree. If a nurse wants to learn more about patient safety or becoming certified, what would you suggest that they do?
Okay, well, I just completed my national certification for patient safety and was successful, so that was good. This is the first time we've ever had a patient safety certification. As you can see, patient safety involves so many different aspects. For the National Patient Safety Foundation, put together a core group of patient safety leaders throughout the nation, and internationally. We also do a lot with Great Britain. And put them together, got them in a room, and for a matter of almost a year, some of us had some input to it. What is a patient safety professional? And it really got down to the core things that came out from it was culture, that you do understand what drives patient safety culture, that you do understand leadership, that you do understand how to take data and use it successfully, and that means learning all the different methodologies for, graphs, for providing data to all different kinds of job roles, whether it's leadership or the end user. And they also focused a lot on the continuing initiatives nationally that are out there. And so as someone wanting to get into patient safety, something that we give our new risk managers that maybe haven't done risk management before, what we call here is our Bible of patient safety. Okay. And it's called Achieving Safe and Reliable Healthcare Strategies and Solutions. A couple of years ago, the Institute for Healthcare Improvement, IHI, which is a key driver of patient safety and also of quality indicators, core values, quality measures of all different kinds. They put together a patient safety officer executive training. And with that, this was the book that they said we had to read before we came because it sets the tone. And it truly does. It goes into not only things that we've already discussed, but it goes into leadership rounding. And how when you go out to visit with staff, you put that on your calendar. You're going to do it at least once or twice a week. And you go out and you visit with staff about key things that they're concerned about with patient safety. And then you get back to them to say, this is what I can do about it, or this is what cannot be done about it, but maybe next year we can budget for it. Mm-hmm. But leadership rounding is a key factor. But it has several different strategies. Team building is another big chapter in this. But it really does go into some key values around patient safety. So I would absolutely look at this book. And the next thing I would look at is the AHRQ. We just discussed it, Agency for Healthcare Research and Quality. They also provide the largest patient safety culture survey that has the largest national data bank. And when we take it each year and we compare ourselves nationally to what's going on, it really has 12 key areas in it. And I think it really drives home what culture looks like. And it's a lot about, there's 3 different sections on teamwork itself. So I think that really stresses how important teamwork is. It stresses leadership. How do my leaders act around me when we get really stressed? Do they not put patient safety first, or do they put that time clock first? That's a key driver of what people think about patient safety. It also goes into event reporting. Do I understand as a healthcare provider that reporting events, whether they touch the patient or not, that they're important for us to report? And I will say that we were fortunate enough in our last round of patient safety culture survey results that we were in the 90th percentile in event reporting. So that was a key driver to us to say we really have made progress with our patient safety culture, because when people feel like they can raise their hands and say, I made a mistake, but they know that they're not going to be held accountable in HR because it was an honest mistake. Mm-hmm. But I want you as the risk manager to know about it so that we can go in and take a look at, how are we going to prevent this from ever impacting the patient? We have event reporting around near misses because we want to know before it harms the patient, before it impacts that healthcare provider. because I call them the second victim. There's not only just the patient and family,
Right.
the healthcare provider themselves, when a bad event occurs, is really impacted with that. And we lose many good healthcare providers because of bad events. So, I'm out there to save them as much as I am for our future patients. So these are key things that I would be looking at. And then, of course, the National Patient Safety Foundation, the American Society of Healthcare Risk Management has a big focus on patient safety. So those are key people that I would be watching if I wanted to begin a career in patient safety. And then, of course, that leads to certification. But the certification, as with all, demonstrates that you are a subject matter expert. And to do that, you have to have a number of years of experience in that particular field so that you do become a subject matter expert. But I think it's a very worthwhile career to follow. I think it's going to do nothing but get bigger because we know that hospital-acquired events are no longer going to be reimbursed. And so, therefore, there's your financial driver to drive down those hospital-acquired events. And so I can see the patient safety officers, even expanding more. And why we drove it with risk management was because with tort reform, we used to be so much in the courtroom and, in depositions and working our cases. But with tort reform in Texas, really the risk managers have been able to do a very nice shift to patient safety and be on the proactive side because that's where we want to be anyway. But we still have events that we have to take care of. But again, tort reform really has changed the focus of risk management as a career path.
Great. Well, Ms. Williams, I would like to thank you very much for taking time out of your busy schedule to answer our questions and provide us information that's pertinent to the culture of patient safety. So it was very nice meeting you.
Thank you very much for having me.
Thank you so much.